DentalReach, made with love for dentist by dentist. Supported by Group Pharmaceuticals. This event is sponsored by M&M Dental Associates and Pulp Dent USA.
It's Dr. Zainab. We are live. Let's start. Please unmute yourself.
Dr. Zainab, you're not audible.
Hello?
Yes.
Yes, you're audible.
Okay. Good evening to one and all. I'm Dr. Zainab Rangwala, your media and PR head for DentalReach. Today we are here to mark the beginning of a unique, one-of-a-kind dental challenge organized by DentalReach in association with our sponsor, M&M Dental Associates. DentalReach is a unique platform that connects dentist to dentistry. We have always been trying to provide you with new opportunities to connect with your peers in the same locality, region, and specialty. In this regard, we have been very lucky that the DentalReach community has always been very active in participating in challenges that we bring to you. The same enthusiasm we expect in this unique challenge. To talk more about the challenge, we are honored to have with us Dr. Rumpa ma'am. Dr. Rumpa Vig is the clinical education consultant at Pulp Dent. She has got a postgraduate certificate in aesthetic dentistry from the prestigious New York University. She is also serving as the president of Indian Academy of Aesthetic and Cosmetic Dentistry. Over to you, ma'am.
Thank you so much, Zainab. Thank you, Team DR and the Divas. I'm excited and feel immensely privileged to throw open the first ever challenge of this country and maybe even the world. I declare the DR Aesthetic Challenge open. So this is the first challenge in a series of 3. The focus today is only on class 5s. And someone who needs no introduction, Dr. Nikhil Bahuguna, will take you through the clinical challenges faced when we work on class 5. I'm truly honored to tell you about the new material that I have kind of covered in all the past Digi conferences organized by DentalReach and Dental Divas. And this Pronto challenge series, is the brainchild post the currently concluded DIA conference. Let's learn the nuances and how Pronto can possibly help us address those problem zones and deliver better long-time results for our class 5 restorations. Now, I'll be here to take your queries and guide you through the challenge anytime you need me. I emphasize anytime. With me, and the backend is the team M&M Dental Associates. They are the exclusive importers for this amazing material, and they will provide the product and all the necessary info you would need to proceed with the challenge. I encourage all of you attending to click the link provided and enter the grand room for viewing the challenge. You will be part of the case by case learning process, and the voting process to select a deserving winner. For each one of you who come forth and apply to participate in this challenge by doing cases and commit to showcasing the same to be part of the competition. I'll be there to guide you if you should need my help. Anytime you need a personal one-to-one discussion, I'm there for you. You would prepare a group of 5, 6, approach me, I'm there for you. Feel free to reach out. That's what we are there for. There'll be a selection of 25 challengers who will be sent samples and info for using the product in their clinics. Idea is to connect from our own work corners, share the yeses, the nos, can we, should we, how to, and much more. We learn how Pronto is different from other regular composites. Use it. Ping me if you face a problem and put up your documented case within 4 weeks. I am an integral part of this amazing pulpit journey. So let's delve deep into Class 5 restorations to start with, and 2 other well-planned series with Pratik and Preeti happening later. My bestest rather, wishes to you all. See you on the other side of FB Pronto Aesthetic Challenge closed group. There you go. Thank you.
Okay. Thank you so much, Rumpa ma'am. Your enthusiasm is contagious. I hope our participants catch some enthusiasm from you. Okay, so now we have Mrs. Mala Malik with us. She is the Managing Director of M&M Dental Associates, a division of Smilesville Private Limited. One of a few women in dental trade, she has come a long way, overcoming many challenges of her own. Over 2 decades ago, she left the high-end cardiac pharmaceutical space to focus her energies on educating clinics to set up an independent profit center for oral proactive care with her signature spa-style appointment concept. A specialized appointment aimed at rejuvenating and preserving enamel, promoting preventive dentistry, and celebrating oral wellness along with whitening. The same passion has brought her today with us with another breakthrough product for Indian dentists, that is the Activa Pronto. Over to you, Mrs. Mala.
Thank you so much, Dr. Zainab. A big congratulations to Team DentalReach for yet another first in the dental industry. Dr. Roxon, Dr. Nupur, Dr. Zainab, you deserve a pat on your backs for sure. I think a couple of months ago, when we began this conversation of doing something different, making a difference to the space of dental education, I could see the enthusiasm that you as a team also showed to do things really differently in the industry. And I think that we have seen all through the year and this pandemic. I would like to take this wonderful opportunity to say a big thank you to our speakers and to our moderator, Dr. Rumpa Vig. Without the speakers or the moderator, I don't think I would have even ventured into this, and I don't think this challenge would have ever come into being. A little about our speakers. Like Dr. Rumpa mentioned, we have Dr. Nikhil Bahuguna, who's going to start challenge 1 today. We have Dr. Pratik Gupta taking on class 3s, and we have Dr. Preeti Lamba, who will be doing anterior restorations sometime in November end. What I'd like to say about the speakers is that they are fantastic presentators. They are amazing practitioners and mentors, formidable mentors. I'm sure you would have attended either their lectures or their courses. before. Coming to Dr. Rumpa Vig, I feel extremely privileged to have her giving us the time for this entire period of 6 months to be a moderator. A lot of you may not know, but Dr. Rumpa Vig, like Dr. Zainab introduced her, is the education consultant, clinical education consultant for our parent company, Patent. But the reason why I'm excited to have her here today is that she has been extremely involved in the research aspect of Pronto. What she knows, none of us know. And imagine if we have her and a combination of the speakers to guide us. We are on a great path to driving excellence in dentistry. And really, that is the purpose with which we come out with this challenge. This Challenger series, literally, my dear friends, comes from the heart. It comes from a zone of passion. And it is our earnest effort to reach out to you, engage with you, and absolutely raise the bar of dentistry that we do out there. Um, a lot of effort has gone into this challenge, and I really hope that you enjoy the challenge as much as we have enjoyed bringing it to you. I hope by now you have realized that this is not just another opportunity. This is the opportunity to get out there, learn, participate, and put your best foot forward. We are all taking it as a challenge because challenges is what takes us further in life. We all have to move out of our comfort zones one day to accept the challenge, and then we rise to deliver our best. And that really is the focus of this series for the next 6 months. I know in the form of Activa Pronto, today we bring you the very best of product that is new and provides many solutions that we have not seen in the past. And that makes it very, very exciting and challenging. And we are action takers, we're doers. We're not here just to listen and forget. We are here to take this product back into your practice and make sure that you achieve the level of success we know each of our speakers have achieved. Dr. Rumpa has seen across the world, and the confidence that you would be able to implement this revolutionary system in your practice. We look forward to an exciting 6 weeks together. I can't think of a better platform and a better way for us to celebrate our 25th anniversary as M&M Dental Associates, servicing this uh, fabulous Indian dental community. I am extremely grateful to you guys for all your kind support. And I have just one thing to say: your success is our success, and let's keep inspiring each other along the way. Thank you so very much. Look forward to you on the FB group. This is a closed group so that together as an insulated community, we can explore the challenges and the product Pronto together. Thank you so much, my dear friends. Over to you, Zainab.
Thank you so much, Mrs. Mala. It has always been such a pleasure to work with you in all the previous events as well. Thank you for your support. Thank you
Thank
so
you.
much. Okay, so now we have with us Dr. Nikhil Bahuguna. Dr. Nikhil Bahuguna is an MDS in Conservative Dentistry and Endodontics. He is the diplomat of American Board of Aesthetic Dentistry. He is a certified Malifier, Adervis, and Light Speed instructor. He is the secretary and board of director of Indian Academy of Aesthetic and Cosmetic Dentistry. He is also the former professor and HOD in Kalka Dental College, Uttar Pradesh, India. He is the key opinion leader for Pulp Dent, and he owns a private practice in Noida, India. Today, he will be with us discussing Class 5 and the use of Pronto. Over to you, Dr. Nikhil.
Thank you very much, Zainab. And thank you, Dr. Rumpa and Ms. Mala, both of you, for agreeing to moderate and have me here as a speaker. So I would not waste much time. We'll start with the presentation for today. So do I have the permission to share my screen?
Yes,
Zainab?
sir. Yes, sir.
Just give me a my screen visible now?
Yes, sir.
Okay, warm greetings everyone, whoever is logged on and who are sitting here right now with us, enjoying this Saturday afternoon. As we usually say, Saturday afternoons are best invested to education. We've always been doing that. There's just a small tradition I always follow before I start anything good. And this auspicious challenge today, I would want to kick start by the blessings of the Lord Almighty. And I've been very kindly introduced by Zainab already, so I will not take too much of a time in showing what I am and what I have done. Just to run you through the last 17, 18 years of dentistry. The only thing highlighted in red that you would see is the latest addition to the pages that I have for myself. I do have shared space, and I have been involved in some kind of a research or development or education for a lot of manufacturers and propagators across the world. So I do speak for them. But today what you're going to see is purely something which is going to be education based, and it's nothing to do with the commercial involvement with any material as such. Well, just before I start, let me share my journey. Dr. Rumpa would remember this day very well. That was 2005 when I was judged as the best presenter at the Indian Academy of Aesthetic and Cosmetic Dentistry. I did present a paper, something like a challenge that we are having right now, and I got lucky. That's the year when I completed my accreditation examination, and I would encourage all of you to be a part of IACD and take the accreditation examination, which is the biggest test any one of us can take here to showcase our aesthetic dentistry. A few years later, when I was invited to take up the membership of the American Society for Dental Aesthetics, one of the oldest aesthetic associations of the world, was a very proud day for me. And a few years back, I decided to test myself again. And I wrote my exam over there in the US, and I was adjudged as a diplomate of the American Board of Cosmetic and Aesthetic Dentistry. So that's my little journey. For the last as many years, I have been a part of the dental fraternity, sharing and learning while discussing knowledge with friends and colleagues. Well, that's my practice in Noida. It's called Demystifying Smiles. I know the name sounds a little off for a dental clinic, but why this name was chosen is the paper that got me my best prize in 2005 was titled Demystifying Smiles. So I thought it was very lucky for me. I'll just give you a quick view of where I work. So friends, that was my journey in dentistry. So as many things you saw hanging on the walls and kept on the shelves is as many days and times we've had the opportunity to discuss, share our work, and learn from others' experiences in dentistry. I also have an educational endeavor by the name of EduArt Delhi, which happens to be in Delhi. And we also conduct programs for our graduate and postgraduate friends in Noida. So anyone who wishes to have more information can check this out on Facebook. Well, here we are today, starting with the challenge. So before I start, let me thank again the team of DentalReach for having accepted me as a speaker to start this challenge. To M&M Dental, Ms. Mala, who's always been very, very supportive. I'm one of the most enthusiastic ladies in the dental trade that I know. Pulpdent for agreeing to let me present my share of knowledge. And above all, our very enigmatic Dr. Rumpavik, our president IAACD, of which I happen to be the secretary, to having been agreed to become a moderator of this entire Challenges series throughout. Well, I'll just jump into the topic straight away. We were discussing when this entire work was being planned, this entire challenge was being planned. And Ms. Mala categorically told me, see, class 5s are tricky, Dr. Nikhil. I want you to handle it. I still don't know whether it was a compliment or whether it was I was being pushed into it. But the trickiest part was given to me to handle. So I hope I do justice to that. But just to start with the very fact of what a class 5 defect would be. We have two kinds of processes that cause a class 5 decay. One is a caries process, wherein we have the active demineralization happening, which removes the minerals from the enamel and then finally proceeds to the dentine and starts causing more demineralization under acid attack or under bacterial contamination, etc. But this part of, I would say, a class 5 defect is something which is decently manageable because we know the cause. And the cause is bacteria, caries-related bacteria. But the bigger and the more complicated problem, the more complex problem arises when we have the non-caries cervical lesions. Now we call them abfraction, abrasion, erosion, abrosion, which is a combination of abrasion and erosion. People call it toothbrushing defect, or someone calls it a grinding problem. But we have to understand the etiology behind such defects. Only then we can understand why a material like Pronto would be helpful in a situation like this. Well, the pathogenesis of the so-called non-caries cervical lesions lies not in the defect per se, but why it happened. And it happens because of the occlusal mismatch. Now, we can call it bruxism or eccentric contacts or patient not joining the teeth properly or occlusal loss or loss of occlusion centric or whatever. But the fact is, whenever we have unusual loads lying at the cuspal tips or the slopes, they all get translated to the cervical margin and it starts as a minor chipping. And then any other superimposed cause could probably make this defect even bad. Now that's how a regular tooth behaves. We have the normal flexion and the compression happening. So the load is equally either distributed or divided to the tooth. But what happens when the forces change? Now, wherever we have eccentric forces happening, things like malocclusions, things wherein we are doing, sometimes we as dentists are also a contributor to that. When we do not fix the occlusion properly while reducing high points or while doing crowns, there are sometimes we probably, I would not say go wrong, but not right. And that's what creates those minor occlusal interferences or depressions where our cusp to fossa relationship is altered. And the moment that happens, the moment the centric forces which were distributing the load change to eccentric forces, which starts causing a lot of coronal flexion, enamel being very brittle starts chipping over there. Now just have a look here. The lower tooth has been extracted for some pathological reason. This molar is tilting front, this molar is tilting backwards. So as a result, the upper molar the cusp starts dipping into the space and the mesiobuccal cusp is hitting at a wrong angle. Here the problem is not caries, here the problem is the occlusal related issues. So if we have to restore such things, we have to understand the pathogenesis of occlusion and then choose a material which just does not goes and packs that place, maybe aesthetically. It has to be behaving in a manner that when such mismatched loads happen on the tooth, it absorbs it and also repels the residual load. It should be like a rubber, it should be like an elastic. So whenever there is load, it should compress and relate it to the tooth. Else what happens if you have a brittle material over there? Now glass ionomer has been a material of choice for cervical restoration since ages. But the only issue with glass ionomer is it's slightly on the brittle side. Whenever we have chipping here, either it's enamel or any brittle restorative material, be it glass hammer or the older composites, they cannot sustain this load. And the moment we have these crackings and chippings happening, we have all read about the hydrodynamic theory and the neurostimulation theory, which causes sensitivity, and sensitivity is the most menacing problem we have. I mean, we could treat a root canal or extract a tooth and place an implant with precision, but managing dentinal sensitivity is something that we actually lag behind in science, in knowledge, and a lot of in technique. But when we talk about a class 5 situation or a cervical defect, what are the challenges that we face? The biggest challenge is moisture management. Now, I would be tackling all these challenges in terms of how we do a technique and how we choose a material. When we talk about moisture, it's not just the saliva in the mouth, it's more of the ambient moisture and also the fluid which is coming out from the gingival sulcus. Having spoken about gingival sulcus, these defects many times are hidden under the gingiva. And if we cannot manage the soft tissue well, it's always going to be disturbed. Either we end up having too much of a bleeding or we end up having contaminated margins where bonding and adhesion doesn't work. And we have a leakage and sensitivity issues later. Then the occlusal stress, how to handle that, and a material which helps us dissipate that stress. And then a long-term protection, because whatever we do today, it's not going to be stable throughout the life. The mouth will undergo acid attack, there will be demineralization cycle, and our material should be smart enough to move with the times. Well, if I have to summarize all this, I would rather choose a material here which does not point out my mistakes, but helps me learn through my mistakes and is a forgiving material. Now here we have something that we're discussing, and Dr. Rumpa already with quite excitement showed you all those little tubes. So what are these tubes all about? What do they contain and how do they work? Let me just throw a little light onto it. So here I'm going to talk about Activa Pronto. It's a stackable composite. So first let me make one thing clear. It's not a flowable composite that just flows everywhere. It comes in a syringe, it flows out of the syringe, but when you handle it, you will know what stackable means. It stays where we put it. So it's not something that we put on the cervical margin and it's flowing all the way to the incisal edge. It stays. It's sculptable, if not absolutely carvable. And it's a purely light cure material. We do not have a dual cure here like the Activa, which comes by similar the philosophy, which is a bulk fill material. Here it's incrementally filled, purely light cured material. Now the challenge when it comes to the material aspect was to develop something which is light cure first, so that we have command set, we can immediately cure and make it hard. Should not be too many components that we are mixing powders, paste, or double barrels or triple barrels. It should be aesthetic, long lasting, durable. It should bear the loads of occlusal placements. The handling should be easy. The recharge potential. Now let's talk about the recharge potential. We have a lot of things that provide us fluoride, phosphate, and other minerals. But do our regular filling and restoring materials uptake them and also help in creating a balance in the mouth? Well, yes. The answer to a lot of those no's is a big yes today. So here we have a light cure composite which in a single tube, in a lot of shades, and we'll see how, is a beautiful material when it comes to solving the day-to-day aesthetic and restorative issues. Now, it comes with a patented modified calcium phosphate component, which attracts a lot of monomers and then calcium into the tooth structure. It's hydrophilic in nature. It's not hydrophobic. But let me just highlight the word hydrophilic here. Hydrophilic means it's not going to get destructed or destroyed by the presence of minor moisture, ambient moisture, or little wetness on the dentine. Hydrophilicity does not say that if the tooth is full of water or saliva, this will still work. So when you talk about a hydrophilic resin, we're talking about the inherent wetness the dentine has. It utilizes that inherent wetness. It doesn't have an effect like a regular adhesive would have or a regular composite would have, wherein minor wetness starts doing water treeing, water blistering, and hydrolytic degradation. Here it's a biological product. It's like more like a bioglass, which is going to become a part of that moist complex and start the remineralization process while acting as a restorative material. We have a lot of bioactive or biologic materials available, but just for a differentiation, Material like bioglass or MTA or biodentine, etc., they're also bioactive in their own sphere, but they are not aesthetic, they are not load bearing, they do not or cannot be used as a class 1 or a class 2 or a class 5 restorative material. Yes, they may be used for a little base sometime or as a pulp covering agent, but it cannot be used as a final filling material. As compared to that, the Pronto here, it's an aesthetic material which can be used for both replacement of enamel and dentine. And the best part is it is a mineral enriched composite. So the minerals that we talk about, the calcium, the phosphate, the fluoride, is all embedded deep into it. So whenever the tooth needs it, it will send it out. And whenever there's a high demand or a need, it will take it back from the environment. If you see, as we said, it's not a conventional resin. It has no bisphenol, it has no BPA derivatives. It is a urethane-based rubberized resin which is patented as of now. Comes in variety of shades, A1, A2, A3, 3.5, A4. Now, A4 and A6 are beautiful shades when it comes to what I'm going to show today, the class 5 defects. It also has a bleach white shade. So all these different shades give it a huge aesthetic range wherein we can manage everything from an anterior to a posterior situation. The light curing time is about 20 seconds. Please do not alter that. There are a lot of lights available in the market which say cure for 1 second or 2 seconds. Please stick with conventional curing methods, which are your regular LEDs, and cure it for about 20 seconds. It is not a bulk fill material. Please do not pack it completely into a cavity. Put it layer by layer if you're doing a deep class 1 or a class 2. And even in class 5, I'll discuss why we should not fill the entire cavity in one shot. Because we have different parts of the tooth behaving differently. Good compressive strength, good tensile strength. And the best part about this material is it's absolutely good when it comes to deflection at break. It's got a very good deflection bearing capacity. Well, another part of moisture management, apart from the beautiful materials that we have, is how to tackle the extra moisture that comes from the oral cavity. And rubber dam isolation is the gold standard. We have beautiful rubber dam application tips available. We have so many videos. We have so many courses happening. I encourage all of you to start using this, because without rubber dam, bonded dentistry sometimes, I'm not saying every time, but sometimes could get tricky, especially in class 5 situations where it's equi or subgingival many a times. We also have modifications where we, some places where we cannot apply clamps, we can use metal bands along with the rubber dam sheets to isolate the class 5 lesions. We have beautiful blinker clamps, the 212, the Feria 212, the clamps can be used. We can also have the small premolar clamps in certain bigger situations. So it's all about getting convinced to use a rubber dam in a situation like this. Now comes the part of the material which handles or which does not let moisture create a problem. Now, water is the source of life. We cannot think about life without water, the presence of existence of water. And what does this water do? It creates an environment, or I would say it acts like a vehicle for the interchange of all the beautiful minerals that we are talking about, which give the inherent strength to the tooth. Now, traditionally, our restoratives, and especially the bonded restoratives, they do not like water at all. All the traditional materials, and that's why we have that 3-way syringe where we dry it to our might and we say, no, now it has to be frosty appearance so that there's nothing left inside. Well, we should not over dry the dentine and enamel. We cannot dehydrate the dentine, desiccate the dentine. We need to utilize that inherent moisture so that we do not cause future problems. And if we have a material which aids in that diffusion through moisture, which doesn't have any harmful effects in the presence of moisture, at the same time acts even better. So it's a win-win situation. So that negative approach about hydrophobic materials has been overcome to quite a lot when we talk about the recent advancements in materials of the 21st century. It has patented this moisture-friendly resin. One of the first people in the world to have taken a big step, a big leap, I would say, towards understanding the biology of dentine. That we have a moist dentine, we have to accept it as a moist dentine and make a material which embraces the moisture rather than creates a fuss about all the moisture. Just for showcasing the moisture behavior in presence of moisture of this material is, we just take this material and add a drop of water next to it, see what happens. There is no phase separation. It becomes a part. I'm not saying please put water on your restorations. Absolutely no. But all I'm trying to say is that minor moisture from dentine or here and there is not going to degrade, but it's going to be more fulfilling when it is it becomes a part of the entire complex where we are using this material. A big part of management of cervical lesions is the utilization of retraction cords, because they're really helpful tools which help us deflect the gingiva away. Though it's popularly called retraction cord, but I don't believe in the term retraction. They should ideally be called displacement cords. Because when we think retraction, we want to push the gingiva down. But we're not pushing the gingiva down. We're just drifting it away from the tooth so that we can visualize clearly where our margins are. You have a lot of retraction cords available in the market. We can probably choose a small one if we have thin biotype, very thin tissue on the anterior teeth, a medium where we have more bulk required. A large usually is not in my practice. Why? Because when we're trying to push it inside, while pushing and taking it out, the size itself is quite traumatic. But yes, if we have open gingival sulcus and deeper pocket areas, we can use a large. There are dedicated cord packers available. And all these are essentials to manage a class 5 very well. So you nicely place the cord and you can see that the margins have been beautifully exposed. Which was hidden under the gingiva is now absolutely visible for us. Just to share a small video how a cord is packed. We always start from one of the mesial or the distal papillary areas, tack it nicely first so that there is no displacement while we are doing it. And as I said, it's not a gingival retraction per se. We are trying to displace the gingiva away from the margin. So here I'm using a medium cord where I'm just trying to push the gingiva away so that my margin becomes visible. And once you're using magnification in your practices, which again I would request, rubber dam and magnification, two things without which good bonded dentistry is sometimes not possible. Under high magnifier, we could easily now visualize the margin so that it doesn't cause any oozing of the gingival fluid later, because we just end up touching the gingiva even a bit, and that is what causes the entire restoration to fail. Sometimes the moisture is enough, that oozing is enough to contaminate the adhesive process. So here my first cord has gone. I'm using a double cord technique in this particular scenario. So I'm just making sure I displace it nicely so that there is no pulling back of the cord. So once my primary cord is in, the medium cord, now I'm going to put my small cord on top of the medium cord so that I nicely displace the margin, and the margin is exposed absolutely for my trimming, adapting, and other processes. It has to be done with a very gentle hand. The soft tissue should be anesthetized while we are putting the retraction cords. In fact, the first rule of restorative dentistry is profound anesthesia. If we cannot achieve profound anesthesia, even class 1s, class 2s, all class 3s, 4s, and 5s, we will have either a soft tissue getting touched or the dentine becoming sensitive. And that little oohs and ahs and ouches by the patient is very disturbing. That is what sometimes leads us to pull a hand back. Knowing that we could have gone deeper or we could have done a better job, we just try to hold back because the patient was uncomfortable. So you could see now the entire margin is getting so nicely exposed, which previously was hidden underneath. And that's how we can expose the margin in another way by using a gingival retraction cord. And once these cords are in position, we can easily go ahead and we can do our work. So just to show you that how easy it gets, if I'm now cleaning up the cavity, making my enamel margins a little beveled, here I'm using a small round burr. Under magnification and with my margins exposed, if you have a look, cutting obviously on the margin of the gingiva, but the tissue is not getting damaged, neither touched, nor even abraded. So if you notice here, it's fairly easy now for me to work on this tooth without causing any soft tissue damage. Then is another beautiful tool called the lasers. which we use quite frequently in the practice to expose the margin. Sometimes margins are deep inside. This is just how to use a laser. Do not take it a very high wattage. 0.8 to 1 is maximum. Sometimes in a very thick biotype, less than 2, do not cross that. Very slow touch, constant sweeping motion. The angle should be right. So we need to mark the pocket, and then we need to start removing the tissue from there. So just for you to see, there's a class 5 defect, which is partly visible and partly or probably more hidden. It's like an iceberg where only the tip is visible. Now, how do we use a laser at a lesser watt? It's at a 1 watt in a continuous mode. And I'm just trying to trim the tissue away till wherever my depth of the cavity is. And lasers are beautiful tools to be incorporated in a daily dental practice. I do not call myself a laser dentist because laser is not what is giving me my work. It is my work which is giving me the use of a laser. And I know, at least as a restorative dentist, it's a very useful tool where we have to expose the margins, sometimes remove gingiva from a deep class 2, or with a crown prep, just rough so that we can easily record the impressions for a lot of gingivectomy purpose, etc. We can use the lasers beautifully in a daily dental practice. And you can see a few minutes later how the entire tissue is out in a neat and a clean cut. And we have the margin exposed beautifully for either the retraction cord now or the rubber dam to be placed. So it's not that difficult to work. And look at the margins here, which were not visible at all. Now we have absolutely exposed margins where we can visualize the enamel or the present dentine, or sometimes when it's a deeper layer, the blend of the dentine to the cementum. Well, the preparation aspects have to be very clear. We bevel only on the incisal side of the defect. On the cervical side, we just remove all that is rough, those weak margins of enamel or dentine. We do not create bevels there. On the margin here, we are creating a nice bevel. But when it comes to the gingival margin, please protect the gingival margin with a metal band or a metal instrument. This is a special instrument available with which you can pull the gingiva back and then just clear off anything which is weak over there. Now coming to the aspect of how this material helps us in longevity first, bearing the occlusal loads, and also giving that cushion to the tooth, because we all know cervical margin is the most dynamic place. The highest amount of flexion happens there. And if you have a material which cannot withstand and appreciate and accept that flexion and bounce it back, the material is going to fall off definitely. So let's see here how a rubberized resin molecule in this material helps. Now, gone are the days where we used to use the older methods. This is the 21st century. We are looking into revolutionary materials which are going to make our life easy. So it's not the regular HEMAs and the BIS GMS that we're talking about. We're talking about rubberized diurethane dimethacrylate. Now, the similar philosophy that we have in Activa, we have in the same sphere, we have the Pronto. Wherever there is a force, there is a little bending which happens. So the rubberized monomer, what it does is it acts like a cushion on a chair. When we sit on it, it absorbs the pressure, and when we get up, it releases that slowly. And that is a unique property that these particular genre of materials have, this family of bioactive materials have, which make it very useful in high stress bearing conditions. Now, then coming to a chart of the biggest challenge that we face, the acid attack. Now, I could have done a beautiful restoration today. How do I know when my patient walks out whether the hygiene maintenance is proper, whether the mouthwashes are being used currently, the paste is correct, and the food habit, especially when we talk about us as Indians, is varied. I mean, the fact about India is every 200 kilometers, the palate changes, the food taste changes completely. That means more of spices, less of neutralizers. We have a rich diet. We have a very, I would say, a very good diet for the bacteria to thrive and survive. So wherever we have stains happening, we have deposits like calculus and plaque, we have acid attack. Immediately the pH starts changing. And from basic, it gets acidic. Here, what we now start losing is not the hydroxyapatite. Here, what we start losing is the deeper hydroxyapatite material, which did not sustain or which did not fight back to the acid dissolution. Why? Because there was nothing providing it that protection. Well, the answer to that challenge here is we have something which is first hydrophilic. It has a lot of calcium, as we discussed before, calcium, phosphate, and fluoride. All these things together, when they mineralize or they seed into the dentine, they help in neutralizing the acid attack first, so the pH becomes better, and also makes the dentine stronger for the next acid attack. So it protects the dentine at the same time, makes it strong for the invaders to come in the later days. So all these ions, through the moisture present in the dentine, they diffuse and they create certain seeding areas where the entire demineralized areas starts repairing on its own. So let me just show you how it happens. The calcium, the phosphate, and the fluoride, how in a Pronto this works to build the immunity of a tooth. We are going to see the concepts of first diffusion, nucleation, and then mineralization. So let's see what diffusion is all about. Now you have two sides of a tooth. One where there is a bioactive resin, which has the calcium, phosphate, and the fluoride, and the other side where it's attached to a tooth, which is under acid attack. So now the ions, through the little window of dentine, through the moisture which was inherently present, creating that as a vehicle, now starts traveling from the store which is the bioactive resin, and slowly starts diffusing towards the demineralized area. Now when that happens, as and when it is happening, we would notice that the pH starts becoming better. The internal pH of the tooth starts getting better, and through the interface, the diffusion of molecules, the attraction of calcium, phosphate, and fluoride towards the dentine now starts doing something which is called as achieving a state of balance. The pH is neutralized now, the equilibrium is achieved, and acid attack is absolutely negated. That means the chances of recurrent decay, the chances of sensitivity later, the chances of any kind of a restoration issue later is quite aptly tackled. Now, once we have this diffusion, then comes nucleation. Now, this is a beautiful representation of how these bioactive resins work. Now, what is nucleation? Whenever we have these complexes of calcium, phosphate, and fluoride seed into the dentinal area, then they start growing into the dentine. Now, imagine we are sitting and having a cup of coffee, and this is what our material is doing inside the dentine. It's making sure that today it's protected, and also from the future acid attacks, it's being absolutely shielded. This continues till we achieve the pH balance. And once the pH balance is reached, these complexes become stable. And then we wait for the future acid attack again, so that more and more complexes like these can form, and the dentine could be retained as strong and as protected as possible. And now once that is done, we have an actual mineralization happening, wherein we can go into the deeper aspects of dentine, peep into the dentine and see how these crystals are getting formed. Now all this is happening at a super microscopic level. So trust me and you cannot look into even our operating microscopes and go into the tooth and see how it's happening. But trust me, the research on these materials, on biomaterials, has given us an excellent insight into how the tooth behaves once the acid attack happens. And now the protective mechanism of the calcium, phosphate, and fluoride, how does it create the biomatrix inside, which protects the future problems from happening. Now see that as many times we are enlarging, this is almost now going to 100x zoom. And we start seeing the tooth the way it is, the way God made the tooth. And we see these porosities on the enamel, and then how we go into the dentine, the tubules, and how now the material seeps into those areas and creates those beautiful protective complexes which shell our tooth from further problems. So we could just see the kind of dentine which has been protectfully formed by these calcium, phosphate, and fluoride complexes. So the answer to all these challenges that we've just seen is through a material, or I would say a revolutionary philosophy called the Activa Pronto, because this mineral enriched composite is going to provide all that we have just seen. It's a universal material. It could be used in a class 1, a class 2, or class 3. The only place where I haven't yet tried it probably is a class 4 fracture area, and I would wish to probably try it as soon as I probably get more confidence into a class 4. But yes, all the other situations I've tried and it works beautifully well. It's very easy. It comes like a flowable syringe. The tip is small. It could be accessed to deeper areas, which in a video presentation you'll shortly see. It's friendly with moisture. You could use the rubberized resin philosophy, where we have deep class 5s where the flexion of the tooth is very, very tactically important. The shades that we have, especially for cervical margins like A4 and A6, which make sure that our darker dentine is replaced and replicated very, very well. And especially in pediatrics, we have an A1 shade which is very bright, and it doesn't let too much of a stress happen when you're doing work on a child. Well, if I have to compare this material to what actually a tooth wants, it's everything that I want. Right from preservation of tooth structure to friendly moisture behavior, good strength, the release of useful minerals, and the shock absorbing or the rubberized capacity of this material to bear loads. The technique is fairly simple. We isolate the cavity. Depending upon the size of the defect, either we totally etch it or selectively etch it. Apply a nice bonding agent. I prefer a lot of 8th generation bonding agents which are having active moisture control. Place the Pronto in not more than a 2 mm increment. Cure it layer by layer. Finally, do the occlusal sculpting or the adaptation in a class 5 restoration and finish and polish. So we've seen how it works. We've seen what it is all about. But all said and done, it would not make sense if you don't see how it works in a clinical situation. Before I jump into the aspects of clinical tips, just a small recap that we have the bioactive philosophy for a clinical use in terms of a dual cure material, which is called Activa, which is a dual cure. You could use it in bulk. Please do not confuse this with Pronto, which is an absolutely only light curable material to be used in increments. Both of them behave in a similar manner. One is a bioactive material, the other is a mineral enriched composite. So let's now see what Pronto does and the magic it creates for us in the clinical sphere. So whether my V-shaped defect, my class 5 cavity or my abrasion erosion would accept Pronto, let's shoot. So I've taken a documented case here, step by step, so that we can see the management of tissue as well as the use of material. So here we have 2 premolars, one which has an active abrasion defect, which is superimposed by the grinding the patient does. And here a demineralized internal defect, wherein we have loss of calcium. Super surface or the top surface is not affected, but yes, underneath there's a huge decay. Obviously isolated, just to show you at a deeper magnification that the proximal margin was prepared and how we have used a modified technique by placing a cut stainless steel band into that area to isolate that region. Showcasing the bevels, if you notice towards the incisal margin, I have a long bevel, but towards the cervical margin, we have not beveled at all. We've just removed the weak enamel and left it like that. Now let's see how we start step by step. The first step always is we have to etch. This material works only if you etch and bond and hybridize. Whenever we are etching the tooth, my philosophy is very simple. Even if I am into mildest areas of dentine, I would be skeptical about etching the dentine. So here we are first trying to etch at the peripheral part, which is the enamel, and etch all the enamel selectively first. So this happens for about 20 seconds. Once we have achieved a 20-second frame, which if you are keeping a watch right now, you would have noticed we are into a 20th second plus time. Once we have achieved about 20 seconds, now I fill the entire area with my etchant. So this I would do where my dentine is shallow. If it's a very deep dentine, I would just do this much and rely on my self-etch adhesives, my universal adhesives or bonding agents to do the job. Now, for how long do we etch the dentine after that? We just wait for about 7 to 8 seconds. By the time my syringe is out from the tooth, my suction device should go in. Because if we etch it for longer than 10 to 12 seconds, 15 seconds, it's going to cause a lot of problem. I'm using a micro tip applicator to suck all of the etchant off. Make sure the tooth is washed nicely for about 10 to 15 seconds so that there is no trace of the etchant left. Once that is done, we use a chip blower or a three-way syringe with very mild air pressure to dry it. Now comes the bonding. So we've changed the LED now to a green light so that it doesn't interfere in bonding. But now we use a universal bonding agent and go by the manufacturer's instructions. If they say scrub it gently, please scrub. If they want you to agitate it, agitate it. If they ask you to just apply it and leave it, it all depends upon the kind of acidic pH it has, and also the kind of monomers it has, or the basic ingredients it has to cause the hybridization, to form that hybrid zone. Now here what I've done is applied one coat, wait for a few seconds, using a chip blower, a manual chip blower, gently air dry, and apply the second coat. Between the two coats, the time should not be too much, the time lapse should not be too much, because when the adhesive is being carried inside the dentine with the help of the monomer it has, if you leave it for a very long time, it all evaporates and we don't have any adhesive which is going inside. So gently air dry again, make sure we use a nice blow of air till we see fluttering on the tooth of any kind of a moisture, we see those bubbles forming, we have to keep on drying. Once we have a moist surface which is shiny, as you see here, it's not wet, it's very, very moist and shiny. That is when we go ahead and we light cure it for as many seconds the manufacturer has told us. This would go under a 20-second cure because the bond that I am using is a 20-second cure bond. Now we have applied the etchant, we have applied the bond. Now what next? We start the application of the Activa Pronto. Now you would notice here that when I am trying to go ahead with my Pronto application, I'm not going to go in bulk. I'm going to take my syringe, my dispensing tip, and first mark my enamel areas. So the first little shot goes into the deepest area where I have my enamel periphery. And I just fill that much up. Because we have to understand one very simple logic. The enamel over here is all supported. The enamel at the periphery starts getting unsupported. Over here and at the margins, our enamel does not have a lot of support. So if we cure in one bulk, the lower part or the stronger part of the enamel will have the tendency to pull the other material towards itself, which may probably have a microscopic gap at the end. So I always do it incrementally in even class 5 situations. Now once we have done the application, I'm going to take an instrument and just adapt it nicely. So you see it is flowable. In the previous clip you saw it's flowable. It nicely flows into the area, and now you're seeing how adaptable it is. With a thin probe, with a thin modified probe, I can just take it and tack it to my margin. I have a small margin here. I could just blend it nicely enough so that I do not have a gap. The nature of the material is such that it is very easily sculptable. It's very easily movable into all those areas. At the same time, it doesn't slump or leave the anatomy that we have covered it with. Once my first increment is done, I would light cure. Cure it for about 20 seconds. And now we go with the second increment. Now here you would see the first increment is already adapted and cured. We are going with the second increment. I would cover my bulk enamel here, my enamel which is strong. I would do that separately, and then I would go to my cervical area at the end so that there are no chances of any pullback, and anything that happens seals my material towards the cervical margin. So I'm creating like a cervical incisal scaffold for my future material to plug in. Now we need to adapt the material to the margins. I use a polymer brush here. It's a flat polymer brush. It's not a bristle brush. It's called a brush because we use it's like a brushing motion, and it comes with a brush handle. But it's a very soft polymer material with which we can nicely adapt the flowable material to the tooth without having gaps at the enamel margin. And on the other side, towards the distal aspect, we're using the sharp tip of the same polymer brush to create the slopes of the cusp and have a nice adapted margin. There goes my second increment. Till now, we haven't filled the cervical margin or reached the cervical margin at all. Now when we come to the third increment, as we discussed, I would now aim towards the cervical areas and whatever I have left with. So if you see, this material nicely flows under pressure. It's not that it's not flowing, it's flowing nicely. At the same time, it's sitting in the position we have left it so that we can sculpt it, adapt it, and make sure we do not lose the anatomy we want to create or the tooth structure that we want to replicate in terms of shape and in terms of size and in terms of defect that we need to see. See, once I'm clear, even at the smallest areas, the moment I have put it at the cervical margin here, it seals, it stays at that point. It doesn't move or move away from the tooth. We cure it then. And now finally coming to the penultimate increment where we seal the cervical part. I know a lot of us feel that it's a small class 5 cavity, let's just fill in one bulk. There are a lot of people who promote matrices for class 5, wherein you fill everything in bulk and you cure it on the top. I probably am slightly old school when it comes to that, because material can get cured very easily, but the stress behavior, the pattern, the stress pattern that the tooth generates when we are curing it cannot be predicted. So rather than joining the top to bottom, wherein the stress of the curing stress would pull the material away from the weaker margins, I'd just rather cure it in 2 or 3 increments. And you just saw all the clips that you've been seeing. It's hardly taken us 3 minutes to run through the entire clip, the series of clips that we have. That means even if I do increment wise, I'm not going to take more than 5 minutes to complete a work. And if I do in bulk, I may take about 2.5 minutes. So if 2.5 minutes is a long time for anyone, please go ahead and do a bulk fill. But I am a little patient when it comes to my cavity fillings. I have lots of time to dedicate, so I do it the simpler way possible. Once this is done, we go ahead. Something which is universal to all resin-based materials that you have in the dental sphere, we have to make sure that we cover it with an oxygen-inhibiting gel. Just give me a second. I think it's just stuck at the video. Just give me a second. I'll be back. That happens when we use technology. Sometimes it doesn't side by us. Gel refill the oxygen emitting gel. The entire tooth gets covered with it and we light it for 20 seconds. Once that is done, we start the trim process. So if you notice, till now my rubber dam is there, my clamp is there, my steel band is there, which will give me the luxury to be very, very clean on the gingival margin, not cause a lot of gingival damage, neither touch the adjacent tooth because of the protection I have. From one side, it's my rubber dam sheet which is protecting me. From the other side, I have my steel band which is protecting me. With a yellow diamond, I'm just trying to remove if there's any excess. Usually when we use a brush for adaptation, we do not have too much of excess. So the adaptation goes fairly fast and we are through with the entire process of cleaning the excess, or what we call as trimming of margins, and sometimes initial polishing. This is a pre-polishing kind of a step that we are trying to do here. And we're almost through the weak material, the extra overhangs are all removed. Try and use it with and without water so that the vision is there. And once you've done a little scratching, use water so that it washes off all the dust. We can see even without polishing, the material starts to shine. That's the nice polishability or the gloss that this material produces. Once we are through with the initial trimming, I use a lot of pogo and enhance. So I'm using a white cone from enhance to do my contouring and my pre-polishing. Once the white is done, nicely wash it, wet the tooth at a slow speed.
Sir, I'm audible.
Yeah.
Sorry to interrupt. Sir, I think we lost your share screen, sir.
Okay, just a second. We will have to. At what level did we lose the screen?
I think 30 seconds back.
Okay. Now, do you see it?
Yes, sir.
So I'm back to my presentation. Okay, so here I think we've seen how it was being finished. Now we just polish it. So I'm again using a Pogo enhanced cup first, the white enhanced cup. Once I have my initial glaze, I would nicely wash the powder off. Now I'm going to use a gray enhanced cones to get my final gloss. Use it at slow speed. Do not use it at a very high speed. And finally, I would use my buff with a polishing paste. Let me go through the video. It's too many videos, get stuff to handle sometimes. So here, just to show that the buff is working on the polishing paste, and that's how the final result comes out. So if you notice here, we have a nice glossy restoration. The margins appear to be seamless. The gingival health is absolutely perfect because of the kind of finish we have, and obviously the isolation that we achieved. And we have a beautiful looking class 5 for the defect here and for the initial demineralization that we had over here. And just to share a few more instances where we have worked with this, there's a class 3 kind of a defect wherein we remove, keeping the marginal ridge intact. We use a lot of ultrasonic diamonds here without using an aerator. Sometimes we do aerator-free dentistry. And that's how the Pronto goes in. And this is how beautifully it's visible on the IOPA. Cases like these, which are daily dentistry, we have 3 class 5s on the 3, 4, and 5. That's with the retraction cords placed. That's with Pronto, and that's post-polishing. The case that I started the occlusal pathogenesis with, the huge defect here, my absolute choice of material would be a Pronto because of its rubberized nature and stress-bearing capacity. Obviously, we have done a little occlusal adjustment here so that the forces are slightly better than before. So that's a pre and post. Daily class 5s that we get. We have 4 in a shot, we complete 4 in a shot. And all of them have been with a similar philosophy that you've seen. An old failing composite, isolated nicely, finished and polished. The other 2 also get the same treatment. Multiple class 5s, case after case I could share. This one was slightly more tricky because we were almost on the verge of exposing the pulpal tissue here. So here I have used a bioactive liner or a base at the pulpal area and then restored it with the Pronto. What I've used here is Limelight Enhanced, which is again of a similar philosophy, has all the good properties that we have been learning, comes from the same pulp dent family. Restorations like these, that's immediate, that's a few weeks later. So that's isolated, etched, cleaned, restored. If you want to see at high magnification, look at how nicely it has blended with the margins. So it's not just another flowable material which will just go everywhere and trouble the soft tissue and the tooth. It sits at its position, it sticks to where it's supposed to be and gives you an excellent adaptability. The same case pre and post. If you look at the shade match, it's excellent. Well, before I end the presentation part from my side, let me just give you a thought from Steve Jobs, that the only way to do great work is to love what you do. If you haven't found it yet, keep looking, do not settle. As with all the matters of the heart, you'll know where to find it. And that holds absolutely true when we talk about the revolution that has happened in the restorative sphere. It's always a teamwork. I cannot grow alone. Had it not been for Miss Mala, who have introduced this product to me, had it not been for people at Pulp Dent when I met them in USA, special thanks to Dr. Larry Clark and Christy, who gave this insight to me about this material, and most importantly, Dr. Rumpavik, who has been sharing the knowledge about this bioactive philosophy since ages. I mean, I could call it ages. She's not that old, but still, she's been doing it for ages. We have a team which can grow together, which can help everyone grow together. And before I end, my favorite game every time, if A is 1, B is 2, C is 3, and so on, what gives you success in life is not luck. It has to be 47. It's not just skills or knowledge or hard work, but attitude. If we have the attitude, if we have the empathy towards the patient, if we respect the tooth tissue, we would always end up doing what is right. And that is what our philosophy is all about. Well, any questions, any doubts, you can feel free to shoot me right here. I'll answer and I'll take as many. I also have a very experienced panelist, Dr. Rumpa, who would be more than happy to answer questions. As Ms. Mala said, she knows much more than any one of us would do, because she is the one who was involved in the research and development of the product. You could mail me or WhatsApp. I would be more than happy to help anyone and everyone.
Sir, it is possible for you to show the last case, sir. Many of them has missed it. Video.
Last case, which one? I'll just let me conclude and I'll go back.
Okay, sir.
Okay, so which case did they want? This one? Rocky, you have to tell.
It was a video, sir. It was a video.
Oh, the entire video you want me to stream again? You know, I lost connectivity because of the heavy videos that we had.
Okay, sir.
So, what I would do is I could compile the clips and I can share it with you. You can put the entire thing on the closed group that we have.
Sure, sir.
Right? Because again, going back, if it hangs again, I'll again have to say sorry to technology. But yes, before I end my presentation, I would want to request each and every one of you sitting out there, please do not lower your guard. Because as we say, second wave, third wave, fourth wave, the only answer is we need to behave. If we behave, there will be no wave. Please, if it's not too urgent, don't get too close to people. Stay away. And probably if you have nothing better to do, relax, stay home, spend quality time with family and friends. Probably nature is giving us time to do that. Well, with that few words, thank you very much for having me here today. Wish you all a very happy dentistry and may all of you get active and bioactive. Thank you very much. So I guess I'll stop my screen share now and go back to the panel.
Okay, thank you so much, Dr. Nikhil, for such an insightful lecture. We are having some questions. If you're ready, we can take in them.
Please go ahead.
One question is, what about the effect of occlusal forces on class 5 cavity? Will it dislodge the filling over time?
See, one thing which I always believe is, between the fight of a restoration and the stomatognathic system always wins. I would rather have a restoration which falls off and tells me that I have an occlusal interference, rather than a restoration sitting hard there and the tooth cracking, the PDL getting affected, the gingiva getting recessed, and all for the smaller good, if not the TMJ and the muscles taking a toll. So I am of the philosophy is use materials which are forgiving, not only in terms of remineralization and demineralization, also they should, the moment you have occlusal forces more than what a tooth can bear, a restoration falling off is a sign that we need to tackle the occlusion first and the restoration later. Class 5s always have to be tackled with some kind of an occlusal correction. So check the interferences, check the extra high points of contacts, and if nothing is wrong and if we cannot find anything or if we cannot do much, at least what we can do is give a night guard or a mouth guard to a patient post multiple class 5s. That will help slightly.
Okay, thank you so much, sir. Another question we have is, how do you control bleeding while placing the retraction cord? Because we need a dry field for restoration. So what are the steps you take for that?
See, the first step always when it comes to gingival bleeding in any sphere, forget only cord, is anesthetize the tooth first. Whenever we give a localized anesthesia or an infiltration, the vasoconstrictors in that local anesthesia are enough to cause cessation of blood flow to that area. Number one. Second is use styptics. There are a lot of styptics available in the market today, which have alum, which have aluminum chloride. You just have to apply there if you see smallest amounts of blood. Sometimes what we do wrong is we take the anesthetic gel or the anesthesia solution and start pressing it. In that, vasoconstrictor is very little. It's more of the prime constituent. Right? Then when I use a laser, sometimes I use a coagulation mode to do it. If you have a cautery, you can do with that.
Okay.
Or if nothing is working, just pack that tissue right there and leave it for a day or two. Because under bleeding tissues, we cannot work.
Yeah.
So we need to respect the tissue's response to whatever we have done.
Okay. Thank you so much, sir. Okay, I hope all the doubts are cleared.
So there
Any
are a
other
lot of,
questions we have?
I can see a question on the oxygen inhibiting gel, if I may answer that. Well, the concept of the oxygen inhibiting gel is when we talk about any restorative resin, it has two sides to it. We have a covalent bond forming. So that is how one increment bonds to the second increment. But if we keep on adding increments, the topmost increment still has a carbon bond hanging up in the air, vying for something else. So now here, it will attract ambient oxygen. And when it comes, it contaminates the surface, doesn't let it cure properly, neither does it let it set properly. So we apply a layer of pure glycerine. It's a medical grade glycerine, not Vaseline, because Vaseline will leave residue behind. Nothing which has got any resinous extracts. So pure medical grade glycerine can be used. KY jelly is one of the oldest products available, though it's not available for a dental purpose. For dental purpose, we have very good oxygen-inhibiting gels by Ivoclar Vivadent, by Circamed. You usually use the one which is by Circamed. I've been using it for as long as they're in the market. And then when you apply the gel, you have to cure that gel also. Though the gel doesn't become hard, but acts as your topmost layer of composite. And then just wait for 10 minutes for the initial decompression to happen and start your trimming process.
Okay, thank you so much, sir. Okay, so I hope all the doubts are clear now. And in case if you have any other doubt, we have our mentors with you. We have provided with the email ID and the WhatsApp numbers. You can contact them and you can clear your doubts. So with this, we let this challenge open for everyone for participation. Participants will have 1 week to submit their registration form. They will have to submit it by 7th of August. Then by 1 week, the participants who will be selected by our sponsor company M&M Dental will receive a sample of Pronto material, and then they will get 4 weeks to complete the challenge and submit the case. All the Indian practitioners are allowed to participate in the challenge. The condition is that they should be in practice for at least 22 years and should be well versed with the use of composite material. In case of any queries, you can always contact on the number provided and the email ID. So thank you so much to all our mentors, Dr. Rumpa ma'am, Dr. Nikhil, Mrs. Mala. It was a pleasure, a very insightful lecture, Dr. Nikhil. Thank you for your presence, Dr. Rumpa. Thank you.
So do we have the permission to leave the meeting now?
Yes, sir. Yes, please. Thank you.
Thank you. Thank you.
Bye, everyone.
Bye. All the best.
Bye. Bye.